Dr. Beccy Cooper first. Thank you.
Thank you, Chair. So thank you for being here this morning. I want to continue a little bit where Andrew left off with workforce. And it's great, Secretary of State, that you are so incredibly keen on the community. So let's stick with the left shift. So I wonder if you can outline how you're developing our prevention workforce, both in and out of the NHS. So I'm thinking specifically of that community workforce, but also, of course, our voluntary and community sector and our public health workforce, which I appreciate is in another directorate, but is still intrinsic to what we're doing.
In a few ways. Firstly, we've worked hard, particularly as a ministerial team, but also with the new leadership we have on both the official side in the Civil Services Department and in the NHS Executive as well, to improve and build on the relationships we have with local authorities and local government, particularly directors of public health, DASs, DCSs, to make sure, and actually even some of the place-based directors in local government, to make sure that we are implementing health in every policy in local government as well. They're part of our workforce planning and that conversation.
Are they, Secretary of State, part of your funding planning? Because one of the conversations is absolutely this conversation that nobody disagrees with, but you'll appreciate that the funding is still going into the acute sector, and I very much realise why that is the case, because we've failed to prevent people getting sick for so long. We've got a massive acute problem now. But in terms of looking at the funding, at what point are we going to be able to look at the funding and see parallel funding tracks running? I.e., when am I going to be able to look at public health funding and say, OK, that has some teeth, and when is the community funding going to start looking? It'll never be comparable to the acute sector, but when will we start seeing a significant difference in the funding streams?
So we have, in terms of the public health grant, we have been protecting the public health grant and increasing it to recognise the invaluable work that local authorities do. On the prevention side, we've been pulling a whole range of levers at the centre of government, from changes to the law and regulation, whether getting the smoking bill through Parliament or action on obesity and targeting of junk food and those sorts of policy levers, right through to the Chancellor's decision to introduce a gambling levy. Now, that was brilliant in terms of lifting 500,000 children out of poverty. I mean, there is prevention for you right there, primary prevention. But also from a health point of view, regardless of its role as a revenue raiser, raising that money also helps us to tackle gambling harms as well. So this is kind of in common with some of the other lines of questioning this morning. There is no shortages of things we could do with more money. We've got a finite pot. We have to manage our resources well. And
again, just to press you, I appreciate it's very hard to reduce the spend in the acute sector. I'm not naive to that. But at what point during the sort of course of this Parliament will we be able to say, OK, there are significant resources going into the community sector, and public health is massively under-resourced. I appreciate the increase. Is there a sort of progressive economic plan within health to go, OK, we are going to have to run parallel tracks, and that significantly will mean the acute sector either is going to have to take a hit, I don't know how that's going to happen, or we're going to have to redistribute our resources somehow?
We should see this start to come back through medium-term plans, and there's a few tricky elements of it. So we've introduced this unbundling of the block contract that starts to allow the flow of block funds in urgent care into hospitals to start being released, so that if the care is provided somewhere else, that part of the service can get the investment. But there's always a bit of a timing thing here, where you'd ideally like the investment to go in and then start to see the flow fall out. But again, I think our history on this over the NHS isn't great. When we've tried this before and we've made upfront investments, it's often not been related to shifting flow into hospital, so we've ended up increasing costs. So what we're expecting to see is ICBs in their plans start to set out small steps on neighbourhood care and in prevention and using the unbundling of the block to start...
And this is in their role as strategic commissioner. This is what you're expecting to see. Okay.
And start then seeing patients being treated in other settings. That then reduce income into the hospital sector and fuel further investment in the community services. Okay. The hard bit's going to be the sort of first 18 months, 2 years of it as we start to get things off the ground, prove the work.
Yeah, no, I don't disagree, Jim. It's an incredibly difficult thing to do, and it has been talked about a lot before and it's not happened. So you'll appreciate we're going to keep asking and see if it actually works this time. So in a specific area that we looked at as a committee in the world of prevention and actually clinical services is sexual health services. It was a pretty damning session, to be absolutely honest, and the whole thing is sort of commissioned piecemeal, and the clinicians that run it, the managers that run it, the providers that run it said that it needs to be overhauled. And I know, Jim, when you've been previously, I have raised concerns about at least some public health functions being in local authorities that essentially are, clinical to a greater or lesser extent. Sexual health services very much feel an actual case in point here, and I just wondered what your thinking was around this area. I presume you've read our report.
Me or Wes?
Either of you, feel free. Wes, go for it.
Well, so you're right, and I'll say what I've said before. So when I've been responsible for running these services before, it's very, very hard to work out who funds what, how the money works, who works for who, etc. And it's similar to palliative care. It's a real patchwork around the country.
No, and I appreciate that, Jim. But you are the people to solve this. So rather than admiring the problem, I wonder, are there any solutions, Wes, that you would like to suggest for this issue?
There's been a few things so far. Firstly, to appreciate and respect through actions, not just words, the role that the voluntary sector plays in the provision of sexual health services. And in my early weeks and months in office, that meant, for example, making sure that when we're contracting, that we are recognising the actual costs provided by the voluntary sector and not seeing them as a sort of cheap and easy option, and trying to shortchange them in a way that I think has happened over the years. We have obviously had a big focus on HIV with our HIV action plan, which I'm particularly proud of. But more broadly, UK HSA has been leading work to review our collective approach to sexually transmitted infections. As part of this work, they published their STI prioritisation framework in October 2024, which will allow local systems to work and identify what combination of interventions to focus on, recognising that there is different prevalence and different needs in different communities in different parts of the country. We've rolled out the world's first vaccine programme to prevent gonorrhea, and clinical guidelines have been published by BASH to enable doxycycline to be used as a post-exposure prophylaxis for the prevention of syphilis, which is doxypep. Please do not ask me to explain the science.
Okay, well, all great. So that's great. We've heard all this in the session.
I think
all
Becky,
good.
you're asking.
Yes.
I think at the heart of your question is asking.
I'm asking about commissioning the services. It's a mess.
Is local government the right place for this sort of public health work? So far, the answer has been yes. It's a kind of finely balanced argument, and I think there are some decent arguments for taking some of those services back into the NHS, and I know that's kind of where you're pushing us towards.
Yeah, or I'm just looking for a sort of a sensible way to commission. So at the moment, sexual health services, bits of it commissioned here, bits of it commissioned there. Some clinicians can do some bits, some clinicians can't do some other bits. It's not a sensible, holistic way of looking at
I think that's a fair
person.
challenge, and we should come back to you on that in more detail. And
Great.
We'll go away and take
Have
up
a
the
think,
challenge.
read the report. Lovely. Excellent. So alcohol, Wes, happy Christmas. Can you
feel
just
very seen.
Excellent. Can you just very briefly outline how, as a government, as a responsible government who prioritises people's public health, we can protect people from harm whilst supporting pubs to thrive?
Yeah, look, that is a good challenge. And look, the problem with the problem with alcohol is excess. Generally, in terms of tackling things like obesity and good health whether liver health or otherwise. And we've got a particular challenge with problem drinking and people who drink to the point of dependency or addiction.
So what should we do?
And we should draw a distinction between those things. Pubs are a good thing, and they are a good thing for health. That's not just my view, it is the view of the Chief Medical Officer, no less, because what pubs do in common with other community spaces is provide a place for people to come together and socialise, which is a good thing from a health and wellbeing point of view.
So I think we've established that the cheap alcohol in the supermarkets is the problem. Are we going to tackle that?
You're leading me towards minimum unit pricing.
I'm trying to be quick because I just want to ask you about the gambling as well. So go.
I think this is a debate worthy of our time that Parliament should get stuck into.
We will come back to
minimum
that.
unit pricing. Very quickly, Chair. Sorry, gambling. Should we ban advertising, online advertising for gambling?
That is a matter for my colleagues at DCMS.
But we have a health view on it.
I have a health view on everything. I make sure that they are always put across in cross-government discussions, and there are choices and trade-offs. I'm not aware of any plans to take action in this area.
I would urge you to keep reading our work on this issue.